Good afternoon, countrymen. When was the last time you went for a TB test? That is tuberculosis. Have you at one time had a conversation with your friends or peers or your community leaders about TB? Many of us just prefer to call it TB. TB is one of the killer diseases we have as a country, but it's treatable, it's preventable, and above all, it's curable. Today with me in studios, I have Dr. Simon Muchuru, the TB and HIV Prevention Coordinator from the Ministry of Health, as we're talking about this conversation of tuberculosis. And this program is powered by UGANET, together with TASO Uganda, in conjunction or in partnership with the Ministry of Health. Welcome aboard. Doctor, good to have you this afternoon.
Thank you.
And just to make this conversation much more clear to us and the viewers, what is TB as a disease for starters?
Well, TB is one of those diseases that takes a long time. It is caused by a germ called Mycobacterium tuberculosis. It is spread through the air. It primarily affects the lungs, but can affect other parts of the body.
Wow.
And it is spread through the air when a patient who has TB of the lungs maybe speaks like I'm doing, or coughs, or sneezes, okay? Then the TB germs are projected into room air. And you who doesn't have TB, if you are in that same space, you can inhale that air that is infected with TB germs. They go in your lungs, they settle in. Ideally, the body sends its soldiers, on the white blood cells to fight it, okay? Yeah, but if the TB germs continue multiplying and overpower your immune system, then you can get TB disease. But in many cases, and for most of us, the body's immune system kind of fights those TB germs and kills them off, or imprisons them in some kind of prison in our body, and that state of having TB germs in your body that are imprisoned, they are there, they are not active, they are not reproducing, they are dormant, they are sleeping. With the doctors and the nurses, we call that latent TB infection. So by infection, we mean you have the germ in your body.
But it's not active.
But it's not active. However, if let's say you lose your immunity, and those dormant germs can start reproducing, and they enter into body tissues, primarily the lungs, and cause tissue damage. Now, once they cause tissue damage, that's when you get symptoms. You start coughing. If there's extensive lung damage, you can get shortness of breath. And eventually, it can kill you. The thing with it is that it is a slowly progressive disease.
You've alluded to that it's a disease that takes long, Doctor. Does it take long to manifest, or does it take long to kill? The longevity here is in the manifestation.
Okay, so let's compare it to, say, malaria or COVID.
Okay.
Yeah, so malaria may kill you in a week or two. So with COVID, TB, we are speaking months, 3 months, 6 months. Okay, so that is the difference. Okay, yeah. So it depends on the speed at which the germ reproduces and spreads in the body, causing causing tissue damage.
Now that takes me to the other question. What are some of the symptoms one would possibly have to maybe have a light bulb, like I need to go for a test of TB, or want to think that maybe I have TB already? Because back in the days when we're still studying about TB, over the years, it has equally evolved. Manifestation comes in different signs and symptoms.
Yeah. Yeah, so the primary symptom of TB is a cough Why? Because it primarily affects the lungs.
The lungs.
So this, and so as the Ministry of Health, we have a standard definition of a cough of 2 weeks or more. We train the health workers to think TB. Okay, it may be
2
something.
2 weeks or more.
Yes, 2 weeks or more. You should go for a TB test. However, it could even be shorter. Let's say if you have a cough of less than 2 weeks, but you're producing a lot of sputum, that could be a sign of TB. The sputum may be stained with blood, or it may be kind of reddish or brown. You may have reddish or brown streaks in the sputum. That could be another sign of TB disease. So then they are kind of standard symptoms of TB. Evening fevers.
Oh, you feel a bit feverish.
Yes, especially in the evening. Night sweats. Okay, night sweats. They really sweat. They sweat until the bed sheets are wet.
Yo,
okay,
that's a unique one.
You know, you're sweating. It's not a hot day, but they really sweat
profusely.
Yes, profusely. And then the other cardinal symptom is the much loss of appetite. Okay, and that is why eventually you find that a TB patient becomes thinner and thinner and thinner, and you could actually describe them as someone having slim.
Yes.
Okay, they really become very thin
because of the low appetite intake and all.
Yeah, so those symptoms you'll get in any patient with TB. Then depending on where the TB is, if it's in the head, you may have a headache, or you may have stiffness of the neck. If it is in the abdomen, you may have abdominal pain. Yeah. So,
wait a minute, doctor. Where does it rest at times? Yes, it will attack the lungs, but now you're mentioning other avenues, right? Usually could possibly be settled.
Yeah, so like I described earlier, it first settles in the lungs.
Yes.
Now, if the germs continue multiplying, and especially if you have a very weak immune system, like the very young children, or someone who has low immunity due to other, maybe HIV or any other purpose, I mean any other reason, the germs can then freely flow through the blood from the lungs to other tissues in the body and multiply from there.
Oh,
yeah.
That becomes very deadly.
Yeah.
Well, we are having a conversation about the tuberculosis. If you're just joining this conversation, drop us a feed on NTV Uganda on Twitter. We'll pick your feedback a little later from that as we're discussing this with Dr. Simon. Dr. Simon, Uganda as a country, how many TB patients do we have?
We have about 80 to 90,000. That's what we estimate. Yeah.
And globally?
Globally, about 10 million every year. Yeah.
Every year?
Every year.
Aren't these statistics worrying? That means that every year, are the numbers going up or are they going down?
They've remained fairly stable over the years. And maybe that is largely due to the fact that we are not reaching all of them. We reach about maybe 67% of them. There are many who go undetected. Yes, and up to 1.5 million die every year.
That is very alarming. That's a big figure.
Yeah.
So how do we bring these figures down for starters, doctor? Because we don't want to lose these great citizens of the globe and Uganda in particular. Yeah,
so there are a number of strategies. One is like what we are doing here today.
Awareness.
We are raising awareness. Then we need to, like we've done for COVID, we need to implement TB infection prevention and control. Okay? Let's say if someone walks in a public space and they're coughing a lot, somebody needs to be concerned and check that this person has had a TB checkup. So you would recommend a TB checkup. Let's say someone comes to NTV and they are coughing a lot. You would advise them to have a TB checkup.
A TB checkup, yes.
Yeah, because the mainstay of and the way we are going to defeat TB is through early detection and effective treatment. So and then, I mean, if they are coughing, like a certain gentleman this afternoon told me about his mom who had TB, and recommended that the mom puts on a mask so that when she's speaking, she's coughing, she's interacting with the public, she doesn't spread TB to others. And then the other measures, for example, the way we do it in health facilities, and someone may think it's discriminatory, is that we ask the TB patients to sit aside where we can educate them on how to cover their cough using either their elbow or a tissue or a mask or maybe even a handkerchief. Then what we do is we prioritize them to see the doctor first, so that they spend a little time within the health facility, so that they don't spread TB to the other people in the health facility, patients, health workers, and other people who are working through the facility.
I totally agree. Doctor, there is an assumption back in the day that people who have TB, it's the reason why people possibly don't want to come for the checkups is TB was attached to HIV and AIDS. And everyone who had TB, they would say, maybe they have HIV and AIDS. And the stigma came out so much more vivid in the early 2000s that people would be like, I rather not check, I rather not tell someone that I have TB, where people opted to say that instead of saying that I have HIV, if they tell you TB, you just know someone is infected. What is the Ministry of Health doing about the packaging of the messaging to the last mile on the ground to see that the information is well packaged and people don't feel stigmatized regardless of the situation?
Well, we are raising awareness about, especially of the fact that, one, not everybody, actually the majority of TB patients don't have HIV. Yes, yesterday by around 2008, about 60% of TB patients were co-infected with HIV. They also had HIV along their TB. But the Ministry of Health has managed to bring it down to about 30% currently over the last 1 year. And so, one, the majority of TB patients don't have HIV. That is a key message that we need to put out. Then secondly, TB is curable, whether you're HIV negative or HIV positive. And as we know, HIV is not a death sentence in today's world. So people should, and the other thing is, you know, TB has, for example, it causes you to become very thin.
Because of low appetite and all.
So then you look like what yesterday we were calling them people with slim. Someone, I mean, if you're, for example, very thin like that, it doesn't mean you have HIV. You may have TB, you may have another disease, that is causing you to become very thin. Doesn't mean you have HIV. You may have cancer, you may have something else. So the important thing is to go to the trained people who are the health workers, and then they'll be able to tell you whether you have HIV or not.
Wow. Let's talk about those with TBs. How long does it take for them to be on medication if they go for screening and they find that they have TB? How long does it take for the medication?
Today the medication takes about 6 months, but the World Health Organization has come up with even shorter regimens. For those who have the drug-resistant type of TB, those ones take it for about 9 to 12 months, But again, the World Health Organization has come with newer regimens, and the country is looking forward to adopting those newer regimens, because we do understand that prolonged treatment is such a burden. And so in order to improve treatment outcomes for TB, we are adopting shorter treatment regimens.
I understand. What causes the immune, you've called it the drug immune rejection, that the ones who go from 9 months to 12 months, like when the drugs are not responding positively to the disease? What causes that?
Well, in science, there's what they call mutation. maybe in a simple language, it may be something like maybe Toyota makes a certain type of car.
And it multiplies.
And it makes very many of them, and people get used to it. And I mean, if maybe another company brings a newer or better car, people will be more interested in it. So naturally, we undergo some level of, I don't know how to describe mutation in simple English, but so as the bacteria continue multiplying, they undergo certain slight changes which occur naturally. They are like natural accidents that occur. There are some slight changes in the genes so that the next generation is slightly different from this one. So as these germs are exposed to TB medicines or any other medicine, sometimes that natural accident may be in such a way that it helps the germ to survive this medicine. So if we give these medicines in inadequate doses, maybe you're supposed to take 2 tablets and you're taking 1 tablet, so you're taking a lower dose than you should, then the germ has a greater opportunity
to multiply and resist.
What happens is, let's say if you take a lower dose, you may kill off the type of germ that is sensitive or that can be killed by this germ, but the few germs that have come up that are resistant or that cannot be killed off by this medicine, you give them the opportunity to multiply and they become very many.
Over time,
Yes, over time. And then with time they've taken over, they are the cause of the TB. And so that is why you'll find that somebody who is not taking their medicine well, or if they are, maybe they've got medicine this month and then next month there's no medicine at the health center due to stockouts, such a person, they may start taking the medicine maybe for the first month and they get very well, or for the first 5 months and they get very well. But because there are these few that have slipped through and now they've been given the opportunity to multiply, then you'll find maybe come month 6 or even after they've completed treatment, a new set of germs comes, which is a kind of a new, should I call it a breed?
A new breed, it's a hybrid of the new one and the old one.
Yes, something like that. So they multiply and they cause a disease.
And just look at that brings the reoccurrence of the disease to stay in the body. There is something that Uganda is implementing called the Cast TB campaign. Can you kindly break it down for us to understand it even more?
Okay, so Uganda implemented the Cast TB campaign in March this year, and it is a 6-monthly engagement where we will go out to, we will engage all the village health teams in the country to go around the households that they are responsible for in the village and just visit the household members and check on them. And if they find household members that are having a long-standing cough or any signs and symptoms of TB, they will refer them to the health facility, or if they are able to produce a sample, they will offer them the opportunity to provide a sample, which they will take to the health facility for testing. The CAST in full is community awareness, sensitization, testing, treatment, and prevention.
What is the turnaround time when they take this sample from a person and the return of the results?
Okay, so for the simple test with a microscope that we predominantly used previously, it takes even 15 minutes.
Oh.
If you're just one patient that the health worker needs to attend to. There's a new test which we call Gene Expert. That one takes up to 1 hour to run. Okay, maybe if you add in processing and what, it may take about 2 hours. However, because the same health worker who is diagnosing TB may be also taking off blood for people with malaria, receiving stool and other samples, and doing several other things. The test may take, if it's at that facility, it may spill over to the next day. So the patient shouldn't get discouraged. If the test is not at that facility, especially the gene expert, because the gene expert helps us identify the resistant type of TB, the one that is able to resist our ordinary medicines. So if they provide a sample at a facility, the health worker should be able to look at it under a microscope and then refer another sample. So a motorcycle will come from a bigger lab, pick that sample and take it to the bigger lab. And remember, the bigger lab is receiving samples from several health facilities. So that may take a while. And so our standard and our aim is that we provide a result within 24 hours. However, it may take sometimes a week due to operational challenges. Like maybe the motorcycle comes once a week to that particular health center.
Wow. The conversation is about TB or tuberculosis. Those joining this conversation, we really want to thank you for being part of this conversation. But again, there is a lot that's going on. Dr. Simon, today there is a lot of laissez-faire approach to TB. And I'm sure some of the researchers have reflected as to why the public and the populace of Uganda, to be exact, is relaxed about it. What are some of the push factors that we don't take it as urgent, as critical as it should be taken?
That's a good question. One is we as the Ministry of Health have not talked about it as much previously.
I love that.
As
it should
as we are trying to do now. Okay. So the communities have not known about it. Okay. Two, like I said, TB takes a while to kill. So maybe, if especially if you don't have a low immunity, it may take a bit of time to kill you. It's not like malaria, okay, where you get symptoms, within 24 hours you're down. I mean, you feel so bad that you really get to hospital. You are to, for example, the men.
Our medical seeking habits are bad.
Yeah. So you think of making you think of making money. Maybe if you earn a daily wage, which most people do anyway. So I mean, you're not feeling so bad. You go to work and you don't go to the health facility. Okay, and it's only when it really puts you down that you think of going.
When you're in the age.
Yes. So that's a challenge, and of course people also think about the organizational challenges at the health facility. I mean, if you go to a health facility and you have to sit for a whole day,
it's frustrating.
Yeah, someone will say, maybe let me first do this. Maybe let me first go and have my national ID done,
and then I can come back.
Yeah, or something like that.
And still, doctor, these health facilities, there is stigma again. People with HIV and AIDS usually have their days when they're coming through and they're going to talk to their doctors and counselors. But when someone comes in and they know that they're for TB, there is that segregation. They usually put them on the side. At times it's traumatizing. They feel they are being, highlighted or labeled, for lack of a better word. And you've explained this in the medical terms, that urgently you want them to be attended to, that they can move out and they get their medication. But how do is there a better way we can deal with this as a country?
Yeah, I believe there are better ways.
Like?
Maybe provide them a space that is not obvious to the public, but where they can sit without being a problem to the other patients. But then when you talk about space, then you're talking about construction, you're talking about renovation, which is very, very expensive. Yeah, so I mean, the country has like 6,000 health facilities, and we know that we are not a very wealthy country. So, but alternatively, And that really depends on both sides. If they can be given specific appointments to see a designated health worker, so that maybe you come in at 9:30, I come in at 10, someone else comes in at, you know. But again, our human resource or the number of health workers that we have in our health facilities may not allow for that. That health worker who you want to see these patients may have another line of patients to attend to. So those are the challenges that bring this. But I guess it's maybe we need to position them in such a way that it's not obvious that they have TB.
Okay. Yeah. Let's talk about now the prevention. With all these, you've understood how it's actually got and then how it's treated. Let's talk about prevention. How can I prevent myself from getting TB, even when I have friends, relatives, family members who have TB?
Okay. So one, ask them to go for a TB check if you're not yet sure that they have TB. Then once they are confirmed to have TB, ideally they should, for example, use a mask, okay? So let's say if they are indoors, and preferably they should spend most of their time outdoors during the day, hoping they are not in a slum. Because generally outdoors is better ventilated than indoors. Which provision we may not have in a slum. Then they should encourage them to take their treatment, because once they are on effective treatment, they should stop being infectious within, we estimate, around 2 weeks of effective treatment. Then ask them to manage their sputum well. They shouldn't spit anywhere. Okay, preferably in a closed container, like a tin with a screw cap. They may put their sputum there, and once they are done with it, they should have that sputum buried. Okay, it shouldn't remain exposed to the air, because as the wind blows, as the sputum
carries the germs.
Yes, and the sputum dries, it can carry the germs into the air. Then you've described you're living with a TB patient, so those are things that you can do. If you and now we have new guidance from around 1992. The ministry has recommended that for children with low immunity, those are children under 5 years, if they are living with a patient who has
TB,
kind of laboratory confirmed tuberculosis, those children should be taken to the health facility and screened, and if they are okay, they don't have TB, they should be given tablets to prevent them from catching TB. And if and now there's now guidance that even if you're above 5, you can take advantage of what we call TB preventive treatment. You're given tablets to swallow. The majority are for 6 months. If you swallow those tablets, they'll prevent you from catching TB from your household mate.
Wow, that is the prevention strategy, what we're looking at and all. Let's look at, now that was at home, let's look at transport. So how do I move from my place of work back home and forth when I know I'm a TB patient?
Well, what you need to do, one is to use a mask. Okay? Fortunately, COVID came, so you can hide under COVID. Two, open the windows in public transport so that there's good ventilation. Yeah, and that's what you can do in public transport.
Then let's talk about crowding. We are known for weddings, birthday parties, burials, funerals, and a couple of merrymaking kind of events. If one seems to be, or is already confirmed that is a patient of TB, how do they behave in such crowds?
Well, protect your neighbors.
Wear the mask.
So try and maybe go greet I mean, in a way that you're not affecting people. I mean, you're not maybe hugging or that kind of thing. Make your presence felt and leave. Maybe if the disease is yours, you may not have
choice and all.
A choice. You may have to hang around. But if it's the neighbor, go commiserate with them and say, I'm not feeling well, and you go home.
Doctor, is isolation a good way? If I get to know that I'm infected with TB, will isolation be one way to actually, control the spread and all?
Yes, it's a way of controlling.
For how long? For how long should I be isolated?
For as long as you're not infectious. I mean, for as long as you're infectious. So once you stop being infectious, we will let you know. We do a test which shows that the doctor is no longer seeing TB bacteria, and we'll let you know, and then you can interact with the public. But we mainly recommend isolation for the drug-resistant types of TB, because that type is very difficult to treat. The medicines are more toxic, and it takes a longer time, and it's more difficult to treat. So that is because we don't have enough space in the health facilities, but also crowding patients in the health facilities contributes to further spread. So we recommend a community approach to providing care. So isolation is for those who are highly infectious with the drug-resistant type. That is what we mainly recommend, or those who are too sick to go home.
Okay. Then let's talk about the service delivery. Do we have mobile services for the tests and maybe the awareness, like they come in our slum or in our area, they make a baraza and people get all this kind of information, and in this kind of drive that people are going to actually be tested for TB, and whoever is found positive, they're going to be enrolled or onboarded to the different medical provisions that are present.
Yes, this is something new that we are rolling out. We are rolling out mobile TB clinics.
Wow. How soon?
Well, we've started. So we have 2 in the country that are driving around, okay, and we are importing more, okay.
Well done.
So these are trucks with an X-ray unit inside,
okay,
and we hope to install testing machines inside. So they'll go to places where the statistics show that there's a lot of TB, and then or to a baraza, like you said, where many people come together.
Convenience.
They pass out information that there's free testing here, free screening here, so you can go and they screen you using, for example, an X-ray. And if you found, if your lungs are found to be bad, and we think you might have TB, then we may ask you to provide a sample, which we will test, either in the truck if the testing machine is in the truck. So we have plans to install the testing machines. The trucks came without the testing machines, or with a nearby health facility. So the team that is moving with a truck works together with a nearby health facility, so that they ensure that you get tested, and if it turns out that you have TB, you get treatment from that facility.
Let's talk about the vulnerable communities like the refugees. What is the ministry's kind of strategy or agenda to address the infections in these kind of camps?
Okay, so we, the ministry has engaged the partners, including OPM and the partners that support OPM to manage the refugees. We've engaged them to improve the health services in the health centers which are within the refugee settlements. Okay, we've engaged them and we do provide, when we get, for example, equipment for testing, we provide that equipment. we've engaged the National Medical Stores to provide medicines. We've engaged the administration of the refugees to talk about TB. Okay. We provide them with guidelines. We provide support supervision just to check that they are doing the right thing. So we are doing all of these things, and we have a specific focal point officer who looks at the mobile populations, including refugees.
Oh, that's really good. For the conversation as you've had it, we're going to take a very simple break. When we return, the doctor is going to break it down to us, the kind of food you should eat when you're under this kind of treatment, and how you can actually look out for those with disabilities. The issue of inclusion is part and parcel of what we're doing as a country. But that said, the economic empowerment or the economic burden that comes with you not treating TB. We'll take a break for now. We'll return shortly. Great afternoon, a great countrymen. We're discussing TB and what we call the TB, how to prevent it and how to treat it. Not only that, how to make sure that we actually adhere to the recommendations by the Minister of Health and the World Health Organization, and we stay afloat. Doctor, before we went for the break, we're talking about the vulnerable people. Let's talk about the physically impaired people. How does the ministry reach out to these people, the ones who are either blind or they are deaf or they are crippled? And they're infected with TB? Yes.
Good question. I'm not aware of a specific program for people with disabilities. Usually and I don't know, maybe that it's because there are few in the country. Usually we look at the statistics and we see, okay, there are very high TB numbers among prisoners. So we have a focus on what? On those. On prisoners. Or we are getting high TB numbers in fishing villages. So then we say, okay, let's go with a mobile truck to a fishing village. That is usually what guides us. But definitely, if, for example, you have, because one thing that promotes a spread of TB is crowding. So if you have people with disabilities, maybe in an institution, for example, the mentally ill, we do focus on them, and we've had camps where we go with an X-ray machine, and we've had those patients X-rayed, and we've had a number of them diagnosed with TB. The physically impaired, I'm yet to hear about that. But if they are living, for example, in an institution, they are at a high risk of TB, we can, for example, organize a camp to that institution. Then
let's talk about the risk areas. According to the statistics you have from the Minister of Health, what are the high-risk areas? For example, here in Kampala, or it could be Jinja, it could be the west or the south. Where are the high-risk areas of TB infections in our country?
Okay, so in urban areas, TB is mostly found in the slums. I should say that also where you find urban refugees, there's a fair level of TB. Then in crowded institutions like prisons, like these boarding schools where they are really crowded, we've documented outbreaks. Then in other crowded places like the transport hubs, like the taxi park or the bus park, we've worked with their associations and the Ministry of Works, and we've screened many of the people in those places and found a fair number of them, an above average number of them with TB. So generally, you need to think about a crowded place.
A crowded place.
Yeah.
We should be much more careful about that.
And also in places like barracks.
Okay. Oh, the military or the police.
Yeah. You tend to get more numbers for TB. Yeah.
One would think that taking a lot of tobacco brings TBs. How true is that?
It is true. We find that amongst our, we try to describe the TB patient. So when you come and you're at the front desk of at the health facility, they're going to ask you a number of questions like, what is your occupation, do you smoke, etc. So, and we find that amongst, we find there are many TB patients who are also smokers. So we find that there are certain risks for TB. The highest risk is being a contact, like living in the same house with a TB patient. Those are the highest numbers, followed by being a user of tobacco, followed by other risk factors like being a prisoner or refugee, or maybe somewhere down there, maybe being a health worker or a diabetic or something like that. So those are, so we routinely record that information, and we find that being a smoker. And someone recently observed that we have a lot of TB in places where they grow tobacco, where they use a lot of tobacco, and that is something that we need to investigate and see whether there's any relationship.
Doctor, let's talk about this scenario. I am married, and my partner is infected with TB. How do I protect myself from her? Or if it's me who is infected with TB and I don't want to expose her to TB, how do I protect her? Because, I mean, we're going to hug, we're going to laugh, we're going to kiss. How do I protect myself at the same time, give her all the support she needs?
Well, one, you need to take your medication religiously, because then that helps you to become less and less infectious until you're non-infectious. Two, you can ask her to visit the health facility so that they can check whether she also has TB. And if she does not have TB, we have a medication called TB preventive therapy, or what the health workers call TPT, that she can take to prevent her from getting the common type of TB. And of course, we recommend that the TB patient spends most time outside, because outside is well ventilated, or in a separate room. If you have a big house with several rooms, we do recommend that that they separate from the rest of the family. Like, for example, so a few years ago, one of us did have the drug-resistant type of TB, and the discussions were around having 2 rooms rather than 1 room for the family. Those discussions. But of course, we know that we are also emotional beings, and sometimes we say, okay, let love surpass the TB, and that
if we die, we die.
That is our nature anyway. Yes.
And let's talk about adherence, doctor. Someone could start off the drugs in the first month, second month, third month. Around the third month, it feels like it's something, they're losing the grip, they're losing the battle. They feel like it's not worth it. What could be your guidance on adherence, or what is the strategy to keep the patients on TB to adhere to the medical advice given to them?
Okay, so we need, I mean, if you're the family member, you need to support this person.
Indeed.
And encourage them to take their drugs. Okay? And they really need to set themselves a goal and know that maybe 6 months down the road, I will be done with this thing. Okay? For example, if they are drowsy, maybe they should, if they can, if water is available, they should be able to take a lot of water. If they, for example, are having ill effects during the day, maybe they want to swallow, they want to change their time of swallowing the medicine and maybe take it at night when they are going to bed. And then they need to keep on consulting with the health worker. So they should be able to call the health worker and get advice whenever they're having trouble. For example, if they're feeling bad, am I feeling bad because of the medicine, or am I feeling bad because of the disease. And if something new happens, health worker, what is this new thing that is coming? So the health worker should be able to advise them that, no, come back. We can give you maybe a certain medicine to deal with that new occurrence or that new bad feeling that you're having. And, what was I going to say?
There is someone here actually who has asked a question. Says, Doctor, thank you so much for the message you're giving out, and it's critical. I, for one, had forgotten about TB. But don't the drugs affect us as men? Does it make us impotent? That is his first worry. And then someone here says, a very good afternoon. The conversation is, it's scary for me. We have forgotten a lot about these kind of diseases, yet they're still living with us. You could maybe respond to the first one about the side effects of the drugs of TB.
Yeah, so yes, one of the medicines, but the one which we rarely give for the drug-resistant type may affect one's what is it called?
Desire.
Desire, right? Yeah, but let the health worker know so that they substitute, because I may take a medicine and it doesn't affect me, and you take it and it affects you.
It affects, yeah.
Yeah. Then what was the other question?
The other person was like, it's a little bit scary when you come to think of it, that it can actually kill you before you know.
Well, the beauty about it is it's curable.
Okay. Yeah.
It's curable. It may kill you if you come in late. That is why we need to test early. Okay. It may kill you if your immunity is low, and that is why you need to get the health facility and they establish the reasons why you have low immunity. And in most cases, the health facility has something to do about it. For example, if you're living with HIV, they can give you medicine to boost your immunity. So in many cases, we see that the people who die, usually, especially within the first few months, like the first month or second month, are people who have come in late. We now know that through profiling these patients, which patients are at a higher risk of dying. And that is why, for example, that we are trying to ensure that all people, our goal is that 95% of people who know their HIV status take the antiretroviral medicines which boost the immunity of people living with HIV. That is one of our strategies. We are providing medicine for all people living with HIV to clear any dormant or sleeping TB germs in their body. We want to ensure that all of them receive that medicine, because it provides protection.
Yeah,
and it reduces their risk of dying for even up to 6 years.
Wow.
So those are the things that we are doing. Okay. Yeah.
Doctor, let's talk about proper food and nutrition. What kind of food should someone take when they're having when they have TB? Is there a particular unique food model one should subscribe to or embrace? Maybe, okay, that is on the food they should take. There's something that I had forgotten. When you're a TB patient, do as much as possible to interact with other TB patients. Let's say those you find at the health facility. You picked your phone. If you're on social media, you can search and about stories of other TB patients. Identify with someone who has completed their TB treatment. They'll really be able to guide you and tell you what they went through and what they were able to overcome. To amplify the adherence.
Yes. Then on treatment, we recommend that they take a balanced diet. TB kills your appetite, so we recommend that the family provides sufficient food. Unfortunately, TB is a disease of poverty. So many times people who get TB are also struggling with getting food. They do not have enough nutrition, so their body immunity goes down, and it increases their risk of getting TB. In many cases, people who get TB are people who live alone, who are, due to maybe they are outcasts. And so we need to have community members come around them and give the support. And support them and ensure that they get they get food. So that, because as you start taking your TB medicine, your appetite goes up. And if the TB medicine are strong, if you take them without taking sufficient food, you experience severe side effects. And so,
Doctor, as we're finalizing, what could be your parting shots and a call to action to the public out in the void?
I think for those listening to this show, the viewers, please go out and talk about TB. Watch out for your neighbors, your housemates, your workmates, and politely encourage them to undertake a TB test. The majority of TB tests are negative anyway. So we shouldn't be scared. Yes, so it is only the few that we detect that we put on treatment. Yeah, that is the parting shot that I would have for the viewers. Thank you. Thank you so much, Doctor. Today we have had a very great conversation. At least you and I, we are now in the know of what needs to be done, how to prevent TB, how to treat TB, but above all, how to prevent it is very, very critical. I had Dr. Simon Muchuru, TB and HIV Prevention Coordinator from the Ministry of Health here in Uganda. This program was powered by UGANET, of course, with TASO Uganda, in partnership with the Ministry of Health. I want to thank you so much for being part of this conversation. And next time you hear these conversations, please be a part of them. Now, take this conversation to your communities. Be the champion who is going to stand and just spread the news about TB and how it can be prevented. Good afternoon.